Alright, welcome back to Midnight Med. This video will be on pneumothorax. So the classic presentation might be someone presenting with sudden onset chest pain and shortness of breath. The pain will typically be worse when breathing in and out, and you'll remember that the technical term for this is pleuritic pain. You'll notice reduced chest expansion on your physical examination, and when you listen to their lungs with your stethoscope, you'll notice reduced or absent breath sounds. So what is it? Essentially, it's a leakage of air into the pleural space due to a breakage in the chest wall or lining. And there can be a number of ways that this break might occur. One way might be a primary spontaneous pneumothorax, typically occurring in young, slender males. Secondary spontaneous pneumothoraces also occur, and these are typically due to lung pathology like COPD or cystic fibrosis. Iatrogenic pneumothoraces might occur due to biopsy or catheterization, and traumatic pneumothoraces might occur as well, potentially due to something like stabbing. So what are the risk factors? Well, basically anything that alters the integrity or compliance of the lung tissue will be a risk factor for pneumothorax. Smoking would be one of the main ones, and I guess with this in mind, it does make sense that COPD is linked to pneumothoraces. A previous pneumothorax is a risk factor for a future pneumothorax, and fast growth spurts are also associated with developing pneumothoraces. Genetic syndromes, like the very well-known Marfan's and Ehlers-Danlos syndromes, predispose to pneumothoraces because of their impact on connective tissue. A more esoteric example is Birt-Hogg-Dubé syndrome, which is characterized by the development of multiple benign tumors all over the body, including the formation of cysts in the lungs that can increase the risk of developing a pneumothorax. A pneumothorax becomes an emergency in the case of a tension pneumothorax. Essentially, a one-way valve is created, where air enters the pleural space but can't exit. This causes a shift of the mediastinum and compromises vascular structures, specifically the heart and the great vessels. As for the management, a pneumothorax will resolve spontaneously in many cases. These tend to be the small spontaneous pneumothoraces. Oxygen support might be required. This helps absorb air from the pleural space faster. For cases with a large air leak, a needle decompression or chest drain might be needed. The diagram below illustrates this technique quite well. Surgery might be performed. One type is a pleurectomy, the removal of part of the pleural lining, which helps prevent air and fluid building up in that particular area again. Another is a pleurodesis, where the pleural linings are stuck together to prevent the possibility of air buildup in that area of the pleural cavity again. Specific management of a tension pneumothorax, that emergency scenario I mentioned earlier, requires urgent needle decompression followed by the insertion of an intercostal catheter. I guess the question then remains, how can we prevent pneumothoraces? Clearly, quitting smoking is a very important first step. Preventing recurrence requires avoiding flying for a short period and avoiding scuba diving for life. So there it is, all on one page. I hope it helps. Like, subscribe, and follow us on Facebook and Instagram for more, and we'll see you in the next video.